Hi, this is Teresa Williamson. Today we'll be talking about differential diagnosis in spinal disease. This corresponds to our chapter on the subject. This work is the collaboration of several providers, including Dr. Laura Massey, myself, Dr. Abdelbar, Dr. Kakari, and Dr. Shafri. As we think about diagnosis in spine disease, it's important to consider the clinical presentation of the patient in front of you. Spine care is moving towards symptom-driven diagnosis and treatment, which helps us to narrow into the correct diagnosis and also to avoid incorrect diagnoses. Our algorithm looks at the patient in front of us, therefore, in terms of clinical presentation, their diagnosis, and their history. It splits into pain and neurologic deficit. It's important to note that a patient could certainly have both of these features. When we think about the category of pain, however, we're talking about spinal or axial back or neck pain, and then we're separately talking about radicular pain, pain that's more consistent with paresthesias, numbness, tingling that's going down an extremity in a dermatomal pattern. Thinking about neurologic deficit, we're of course considering weakness, numbness, paralysis, bowel bladder problems, balance trouble, myelopathy, anything to do with compression of a nerve or the spinal cord causing some form of a deficit. Once we've parsed out those important features of the patient's history, we can then ask questions to further elucidate what's going on with those symptoms. We can ask questions about the chronicity of the symptoms. Is it acute, or is it more subacute or chronic? What type of pain is occurring? Is it pain that's mechanical, pain that's worse with movement, acute localized pain, perhaps reproducible by pressing? Or is it associated with a certain time of day, at night or in the morning? Then we ask for symptoms that are related, such as fever and weight loss, other things that we would see on our review of our systems. Same thing when it's going to talk about a neurologic deficit. We're thinking about acuity and also the type of deficit that's occurring. Is it in a dermatome? Is it more consistent with a spinal cord injury? More consistent with a nerve injury? Those types of questions will help us to narrow into diagnoses. At the bottom of the figure, several possible diagnoses are listed, and you can see the way that they are grouped based on working your way through this algorithm. For example, if you have a patient with pain and you notice that that pain is associated with fever or weight loss, you may start to think about a neoplastic process or an infection. In the next several slides, Dr. Laura Massey will talk about spinal deformity and, using a similar algorithm, how to think about patients in terms of their symptoms, and then also as you're diagnosing disease so that you keep the entire patient and their symptoms in mind and make an accurate diagnosis to inform therapy.
Hello, my name is Laura Massey, and I will be discussing the contribution of spinal deformity in the workup of back pain. Our objectives today are to discuss the basic principles of spinal alignment and how they should be considered when examining a patient with back pain. Secondarily, we would like to emphasize that deformity can coexist within the setting of back and leg pain, or it can be one of the driving factors. And lastly, we'd like to discuss the consideration of spinal alignment when formulating a treatment plan, whether that would be conservative or surgical. As an example case today, we can discuss a common clinical scenario: a 65-year-old patient presenting with low back pain, difficulty walking long distances, and some intermittent radicular pain, which radiates into the right anterior thigh. However, what these patients often find most bothersome is standing for any prolonged amount of time. After about 10 minutes or so, they will tend to get an intense low back pain that's a band-like distribution across the lower lumbar paraspinal muscles. What we'd first like to emphasize in these scenarios is that the patient's clinical symptoms should always guide the conversation about any treatment or intervention. And during the clinical exam, it's really our opportunity to tease apart the types of symptoms that the patients are describing into either mechanical, radicular, stenotic, or deformity-related pain. It's really the clinician's responsibility to assess whether these etiologies are interplaying or other factors that are discussed in this chapter could be at play. These could include hip or knee pathologies that can coexist, spondyloarthropathies, or other chronic pain syndromes. In this case, our patient having difficulty standing or walking for a long period of time should raise suspicion for two common pathologies, either spinal stenosis, but also trouble standing for long periods of time is common when patients are describing deformity-related muscular fatiguing from positive sagittal balance. When assessing this patient's imaging and formulating the treatment plan, keeping these clinical symptoms at the forefront of your mind will help focus on structural targets that could potentially be good for intervention. Clinical manifestations of their deformity will really depend on what type of deformity the patient is presenting with. For deformities in the sagittal plane, iatrogenic flatbacks or lumbar kyphosis from prior trauma or infection, these will often manifest as the fatiguing back pain that I was describing earlier with standing and walking that improves with sitting. Coronal deformities often will present more with a radicular picture, either on the concave side of their curve or at the concave side of the fractional curve at the base of the spine. With extreme coronal curves, organ function may become compromised as well. It's often surprising how much general discomfort patients with scoliosis are willing to tolerate when a very large surgery would be required to correct their condition. Triggers for considering a surgical correction of a significant scoliosis, rather than continuing with annual or semi-annual observation and conservative management, would really include the development of any neurologic symptoms, a rapid progression of scoliotic curve on sequential imaging, or intractable pain that's no longer responding to a legitimate trial of conservative measures. Getting back to our example patient, as you can see, there is a mild coronal scoliosis as well as a loss of lumbar lordosis that's quite significant. There is flattening of the thoracic kyphosis, which is often a compensatory mechanism when patients are trying to maintain their posture in a sagittal plane. You can also see that there's some coexisting cervical kyphosis, and all of these would be factors to investigate further before deciding on a course of treatment. Initial imaging for back pain often includes an MRI of the lumbar spine and potentially some radiographic images performed by the referring physician. These can be helpful, especially if they include flexion extension images that might identify a source of abnormal motion. However, weight-bearing full-length radiographs really need to be performed to assess postural parameters on any patient being considered for deformity correction. However, I think they're underutilized in the general degenerative population as well, and can be quite helpful when trying to formulate a treatment plan for even more straightforward patients. Common spinopelvic parameters that should be quickly assessed include the pelvic incidence, the lumbar lordosis, the pelvic tilt, and the SVA. There are apps that can help quickly perform these measurements, or even the electronic medical record imaging software often will have angular and measurement tools. I think the importance of full-length x-rays are usually understood in the cases of deformity. However, I think they may be underappreciated when planning even limited or more common degenerative spinal procedures. Really, if you're planning to do any kind of a fusion procedure, it can be very helpful to have a full assessment of the patient's postural parameters, simply because they may be manifesting an increased pelvic tilt or a flattening of their thoracic kyphosis, which may be near the limit of their ability to compensate. And even doing something as simple as a one-level T-lift, if you notice those postural parameters before your intervention, you may be able to use a lordotic implant or do a slightly larger facet osteotomy to create a little lordosis at that level and take them out of the need to be compensating so much. One last comparison that can be quite helpful after obtaining standing scoliosis films is to compare those with any supine imaging, be it the SCOUT image on the CT myelogram or the MRI SCOUT film as well. This can be very helpful in seeing how much certain curvatures will correct in the supine position. And similarly, if someone is presenting with deformity, often getting either bending films or lateral films with a bump can really end up helping to see how flexible patients' curves are. CT myelogram can also be a very helpful, if underutilized, mode of imaging when planning an intervention on a patient that has a history of a prior fusion. It really allows for improved visualization of the neural elements and bony structures at those previously instrumented levels, and allows for a very helpful assessment for any pseudoarthrosis or suboptimally positioned hardware that should be addressed in a repeat intervention. It is to some degree invasive, and so we usually reserve this mode of imaging for patients who we are planning to proceed with a surgical intervention for. Surgeries to correct a scoliotic deformity should be thoughtfully planned and really only performed after an optimal trial of conservative measures, ideally on patients who demonstrate enough compliance and have reasonable expectations about what surgery will accomplish. Physical therapy for core strengthening is often difficult for patients with mechanical back pain, and so these patients may actually be more successful participating in an aqua-based core strengthening PT program, as floating in the pool will offload their facets. Deformity corrections are some of the most physically taxing spinal surgeries, and these patients participating in any kind of prehabilitation for cardiopulmonary strengthening has been shown to improve patient outcomes. And similarly, targeted transforaminal epidural steroid injections and facet blocks can both be therapeutic but also diagnostic in identifying the levels which generate the majority of the patient's pain. Lastly, neuroleptic pain medications, including gabapentin, Lyrica, Celexa, Effexor, nortriptyline, and amitriptyline, can be considered in patients with some component of radicular pain. And really, a full complement of conservative measures should be targeted and performed before patients are offered surgical intervention unless there is some rapidly progressive neurologic deficit. Often as patients who had a non-operative adolescent idiopathic scoliosis or an iatrogenic flat back deformity begins to age and become symptomatic, it's important to discuss whether a smaller or more targeted intervention that would just address a focal area of stenosis or radiculopathy versus a larger deformity correction is really in their best interest. Often it can be easier to discuss this with patients as the difference between trying to hit a home run or just get on first base. Factors that can help in that decision-making process, which can be optimized during the time they're trying conservative management, includes an assessment of the patient's bone quality, smoking status, and overall health. These are largely elective cases, and so performing a fusion on someone who's still actively smoking is probably not in their best interest. Similarly, a cardiac workup and stress test is performed on anyone over 65 in our practice, or anyone with a cardiac history younger than that age. Most importantly, repeated visits and conversations about the patient's symptoms, goals, and establishing realistic expectations are really of the utmost importance. Often, patients with a pronounced scoliosis can expect about 50% improvement of their pain, and they're usually willing to take that risk so long as they are really at the point in their life where their symptoms have become unsustainable. And it is often possible to achieve results greater than that, but when patients have a realistic expectation, they're often much more pleased when they find themselves doing even better than they expected. Similarly, smoking cessation and documented evidence of such prior to any large instrumented fusion should be nearly non-negotiable. Deformity corrections from T10 to the pelvis or T4 to the pelvis really leave very little room to correct if these factors are not optimized prior to surgery, and patients should be aware of the risk that they face if their fusion construct were to fail from a modifiable risk factor. Often sending patients for a bone density scan even months or years before a planned intervention might become necessary can be of value, especially as if a patient fits into an aging population, as the treatment to improve patients' bone quality can take up to 2 years to really manifest. Prior spine fusions and degenerative changes in the vertebral bodies will really alter the measurements of the bone density in the spine, and so for these reasons, we often will send patients for and assessment at the wrist and femoral neck. Having a good collaboration with a bone endocrinologist can really help distinguish patients who might benefit more from an aggressive anabolic bone agent for 6 months or more to actually build the bone quality in an osteoporotic patient. Often patients who have a pronounced coronal scoliosis are actually at risk of that progressing if they are found to have weakened bone quality. Ultimately, different surgeons will have different preferences, and especially as technology continues to evolve, whether these interventions are performed minimally invasively or open or from posterior, anterior, or lateral is really beyond the discussion that we're having today. However, what we hope is very clear is that no matter what technique someone ends up utilizing and feels most comfortable with, incorporating some of the basics of these deformity principles into one's clinical exams, treatment plans, and just mindset and overall workup can be very helpful, whether they're dealing with a deformity patient or even a more straightforward degenerative practice.